great pleasure that I welcome to IHME today Caleb Stowell. Caleb is Vice President, Research and Development for the International Consortium for Health Outcomes Measurement and Senior Researcher at Harvard Business School. Caleb did his basic medical training at Harvard and then started working with Michael Porter. It's a name I'm sure is known to many of us here, and worked with Michael Porter on some of the major research that the Harvard group has done, for example, in value-based healthcare, and has stayed with that group, and now, as I said, is playing a major role in the development of standard sets of health outcome measures. So I'm sure we're all very interested to hear what you have to say. Your talk is titled, "How Can We Tell If Doctors Do Any Good?" So, thanks, Caleb.
Thank you. It's a pleasure being with you today. I have the distinction of coming to the other institution in the US who has a long name with an abbreviation that sounds somewhat like ours. So I've always been interested in the work that you do here at the IHME. And now I've gotten to meet your director and hopefully get to meet some of you through the seminar today. But to start us, I want to take us back actually 100 years to the story of a fellow Bostonian named Ernest Codman. Ernest Codman was a surgeon at the Mass General Hospital, and he was facing a challenge. He thought that his outcomes were better than his colleagues, and he had no way of proving it. He thought he should be promoted over them. So he talked to his colleagues and said, we need to measure the results of our care. He called it the end results of their care, and we need to make them transparent. And as you can imagine, his more senior colleagues weren't so thrilled with the idea. So Ernest Codman left the Mass General and started his own hospital, which he called the End Result Hospital. The problem was that Ernest Codman wasn't as financially successful as he was clinically successful, and the End Result Hospital eventually died. But the idea of measuring end results, of measuring outcomes, in many ways was born in a systematic way through his work. This is a paper that he wrote in 1914, so 100 years ago today, where he challenged what is being measured by the Mass General Hospital. And as you can see, I don't know if you can see in the back, but around the circle he said, look, there are categories of things we measure in healthcare. There are administrative things we measure, including how many patients we treat, how long those patients stay at the hospital, how many beds we have. There are things we measure about our education, how many doctors we train, how many nurses we train. And there are things we measure about our, in a way, reputation, our scientific reputation, the papers we publish, the influence we have as an institution on medical standards. But he said what we don't measure is there in the middle, the results to the 6,896 patients. And that is really the goal of ICHOM, to take the measurement of healthcare and focus it on what actually matters, which are the results to the patients. In that paper, he wrote this quote, which in many ways we could write as our own mission statement here at ICHOM. I'll give you 15 seconds to read it so that I'm not reading it for you. So I give you this so that you understand I'm not coming at you with something I'm claiming is new. It's an idea that's been had before, but we feel as an organization that now is the time to take that idea and to put it into practice. And to give you an example in a bit more detail, how has the world changed in the last 100 years? I want to tell you about localized prostate cancer. Now, many of you are young and have decades before you have to worry about this, but we have some older gentlemen in the room who, at least some of you, are likely to develop prostate cancer. 1 in 6 men. That's the most common male cancer in the world. And the decision of whether to have treatment, what treatment to have, and where to seek that treatment is actually quite a complex one. It's not something that really kills people. Prostate cancer is something you typically die with from something else, but you have it because it's quite slow growing. And so if you are going to seek treatment, you're going to have either an operation or radiation done to a part of your body that you may want to protect. Then you face a decision of what are the risks. You may gain a survival advantage after 15 years, but what are the risks to you as a person? And the challenge is that data, that risk of data, is not available at an institutional level. So what is available is this. This is what everyone knows is the US News and World Report. This is actually not for prostate cancer, it's for cancer as a whole. But if you were a patient with prostate cancer asking yourself, where should I go and seek treatment, you would often find yourself, particularly if you're going by the promoted ads on Google, to the US News and World Report website. And you would find these highly reputable institutions listed. So many of you, particularly if you've practiced medicine, would recognize these names. Names like MD Anderson, MSKCC, Mayo Clinic, and Hopkins. But the method of coming up with these rankings is quite poor. I know you are all methods people, so I listed what the method is. 33% is on reputation. 33% is on in-hospital survival, and the other 30% is other. So if you reflect on the fact that prostate cancer kills people over 15 years, and these are the measures that you have, the correlation between these measures and success in those, totally unknown, right? And yet this is the information people are using to make their decision, which is why they primarily go based on reputation. In fact, if you look deeper, the only thing that's driving these differences is reputation, because the in-hospital survival for most of these is nearly equivalent. So why is that a problem? The problem is because the variation in meaningful outcomes does vary. Now, unfortunately, we don't have data from the US, but we do have data from Germany. A health plan in Germany conducted a study of patients who've been treated for prostate cancer to assess more meaningful patient-centered outcomes. Now, the 5-year survival for these patients, as you see here, actually that should be 96.7. Not sure why those numbers are that way, to be honest. The survival for prostate cancer is actually 95 and 94%. So the bars are correct, but the numbers at the top are not. Very little difference between the best hospital and the worst hospital. But when you look at incontinence and when you looked at erectile function, you see huge differences. I'll get to your question in just a second. The partial incontinence rate, the methodology there is asking patients via questionnaire if they require pads and how many. That determines the level of incontinence. The best hospital, only 6.5% of their patients at 1 year suffer from incontinence versus 40% at the average hospital. And with erectile function, still more of a problem for receiving the operation, but 34% versus 75%. If you were a patient facing a decision of where to receive treatment, would this data be meaningful to you? That's the question. Yep.
Is this best hospital one hospital, or is it best hospital?
It's one hospital. It's the one with the best outcomes.
Okay.
Yeah.
In everything?
Yes, survival, it's in the incontinence and erectile function outcomes, the patient-reported outcomes.
Does the best hospital take in, or sorry, do these measures take into account that the patients going to each of these hospitals would be probably different?
So the risk adjustment here is poor.
I don't know.
So the risk adjustment is the case mix adjustment. It's the term for distinguishing what are the different characteristics, the clinical characteristics of the patients and how those influence outcomes. So you'd want them to be better risk adjusted than these are. They had available administrative data they used, but whether the point estimates here between them are perfect, they're not. But directionally, they tell us something. So why is this best hospital that much better? That's the question, right? Is this a statistical fluke? I don't think so. So we looked into the best hospital. Why are they different? It happens to be that Germany has the largest volume prostate cancer center in the world. They treat 2,000 patients per year. And it's a team of 9 clinicians who, interestingly, are from a range of specialties. but are all paid the same, are all the same rank of faculty, and work together as a team and have been over the last decade. So their volume is, some of them do close to over 200 prostatectomies a year, whereas we have in the US some surgeons, 25% of surgeons here that do prostatectomies do one a year. As you can imagine, a very technical operation, you might get a little bit better doing 200 versus one. What they also do, in addition to doing more, is systematically looking at their outcomes. So this is, at the left here, this is an incontinence score, the International Index for, or sorry, an erectile function score, the International Index for Erectile Function. And this is the range of outcomes that the individual clinicians are getting for their patients. So every quarter they sit down together with this very long slide deck and they look at their outcomes. Who's achieving better outcomes than others? And if someone is an outlier, that person is forced to scrub in and participate in the surgery of the person who's a positive outlier. Interestingly enough, the founder of the clinic in the last, in a report, was actually the outlier, the negative outlier. And he, even this 70-year-old gentleman who's in the last years of his practice, was scrubbing in with a young buck who was the leader, really, in outcomes. So not only do they have this system, but they have a systematic way of looking at the literature. So every week they assign someone the responsibility of surveying any new literature in the urological field, and that person then condenses it and says, this is how those recommendations should change practice. And through that, they're able to systematically gather evidence, test innovative practices, see their impact on outcomes, and improve their outcomes over time. So the question is, if you are a patient being treated for prostate cancer today, you wouldn't know whether the center you're going to has these outcomes or not, because again, we are generally ignorant. That was an example of prostate cancer. I would tell you that nearly every condition has variation. Of course, you're all, either you are statisticians or you have an interest in data. You know that things occupy a distribution. It's no different in healthcare. That distribution ranges from a fairly narrow 2x distribution in mortality rates from heart attacks in the US, 4x in bypass surgery in the UK, 9x prostatectomy complication rates in the Netherlands, 18x variation in reoperation rates in Germany, 20x mortality in Sweden for colon cancer surgery, and 30x capsule complications in cataracts. There is variation. We know this. Within a local level, we know it on a limited set of outcomes. The question is, what do we do about it? Typically, we've hidden behind the variation. We've used excuses to say, well, we don't know whether the patients are truly comparable across populations, or we are afraid of whether our institution is at the bottom of that list. But our view is we have to see variation as an opportunity. For every negative outlier, there's a positive outlier that points the way for improvement, and it's not going to go away unless we address it. So ICHOM then is based on the idea that measuring outcomes, meaningful outcomes, in a systematic way is at the core of transforming healthcare. This is a quote at the top from Michael Porter's book, Redefining Healthcare, that came out about 8 years ago, which laid out a vision for how focusing on outcomes would transform healthcare. And that includes its impact on patients, which we've discussed, but also the impact on clinicians who today really don't know systematically whether they do any good and how that compares to their peers. And of course, health plans want to move away from paying you for everything you do, including the rates of complications that you achieve, but they can't do that without meaningful indicators. So this is the goal of ICHOM, to achieve this world. ICHOM is founded by Michael Porter from Harvard Business School. It's founded by Stefan Larsson, a physician scientist from Sweden, from the Boston Consulting Group, and from Martin Ingvar from the Karolinska Institute, also from Sweden. Now, the Swedish partners, you may ask why US, Sweden, but Sweden happens to be quite good in data and quite good in tracking outcomes. So for those of you from Scandinavia, you would know that. They make for good partners. And we started this initiative as a nonprofit because we felt it was a political movement to try to encourage measurement of outcomes in a standardized way. And we needed to do that in a way that brought everybody to the table.
When was it founded?
So late 2012, a year and a half ago. And we're very grateful for a number of sponsoring partners, mostly provider organizations who see an outcomes focus as the future of healthcare and want to be a part of it, but also patient advocacy groups like Movember and the American Heart Association, which is not up there yet, who want to push more promotion of outcomes that matter to patients. So this is our agenda. This is what we're trying to do to get to that world of value-based healthcare. The first is to define what outcomes matter most to track for patients. And do that internationally, because this is not only a problem facing the US, it's facing every advanced economy in the world. And the second is to make it easy to do that. We had a great conversation, Martin, about how difficult it can be to get meaningful outcome data. What we're doing is engaging with the technology providers. We're creating simple solutions so that people who say, I get it, they can get started. And then we're creating communities of people around the world who want to measure outcomes and providing a mechanism for them to get together to compare and to learn from each other. And lastly, we recognize that those first three are more of a bottoms-up approach. We need some pressure from the top to get people moving in this direction. And that's why we're engaging with payers and governments to push these into their reporting requirements. I'll run through a bit of background on each of these to give you a bit more detail. So we organize, to develop these standard sets, we organize working groups with clinicians and patients from around the world to define the outcomes that matter most to them. And we walk them through a structured process in a working group to have a document that everyone agrees with and says, this is what we should all be collecting. Now, the document at the end of the day doesn't look like this, and it doesn't have signatures. It's more of a publication, but this is the principle. We work with a framework that tries to think about a comprehensive set of outcomes that matter to patients. This is a framework developed by Michael Porter, and it includes, if you were to go seek care as a patient, you'd want to know whether that care benefits you, either in your longevity or in your quality of life. And that's really the top piece. What's the benefit that achieves to you in the short term? But every treatment, or at least most treatments, have certain risk attendant to them. And you want to know, to what extent do I have to spend my days receiving treatment, the time to recovery, and time spent? And to what extent are those treatments causing complications that are either painful or damaging to your quality of life? And then what effect does that treatment have over time? Is, if you give someone a hip replacement, how long can they expect to have their improved functionality with that treatment? So this is a framework that we apply in every condition to decide what are the outcomes that should be collected. And we walk the group through a structured process. So the people in the group are often those who have experience either developing measures or those who have experience in putting together an infrastructure at a regional or national level to collect them, and then patients. And it's a process of taking, not quite boiling the ocean, but thinking of what could be collected and narrowing it down to what's most important, how to define it, when to collect it. And this is really the process that ICHOM plays as a facilitator, is to drive to the consensus of what should be in that set. We do it for outcomes, and then we repeat the process for risk factors or baseline characteristics so that the outcomes are risk adjusted. This is the group for prostate cancer as an example. You'll see that most of the people represented are from advanced economies. Our view would be that this work is relevant for developing economies, but the infrastructure required for them creates an extra barrier. So it'll be something that they will want to invest in over time, because as a developing country health system, the idea of being able to benchmark your performance against the leading centers would allow you to more rapidly transform your health system than if you didn't have that information. But the primary target at this stage are advanced economies, particularly for a condition like prostate cancer, which is in its old age, and the mortality benefit is small. This is the set. You already are now familiar with problems of prostate cancer, so in a way you could have predicted this. People who are receiving care in the top right care about what's the immediate impact on them. You know, in receiving my operation, to what extent, what's my risk of actually dying as part of that operation? Or having a pulmonary embolism, having a DVT. What are those acute complications I have to worry about? But the things that are really important to these sets are the patient-reported piece. What's my level of incontinence after receiving treatment? My urinary frequency or obstruction, my bowel irritation, sexual dysfunction, vitality. And then what's the ultimate impact? What's the benefit I get? My biochemical recurrence, that's a measure of when the cancer recurs. Metastasis and cause-specific and overall survival. So this wheel attempts to circumscribe what are the most essential outcomes a patient may care about in seeking treatment for this condition, and it's relevant for all treatment options. So the focus is then that no matter what treatment option you provide, you should measure outcomes and be able to help a patient make a decision of whether to get treatment and what treatment to get. Now, for those of you that know clinical practice, the treatment you get for prostate cancer, the biggest predictor of that is the type of physician you go see for your prostate cancer. So if you go see a surgeon, you're likely to get surgery. If you see a radiation oncologist, you're likely to get radiation. People interpret the data in different ways. It's very rare that they would actually show you data from their own clinic. So that would be the goal. And then with every set, there's a corresponding list of risk factors or initial conditions. In prostate cancer, it would include the stage and grade of the cancer. It would include their comorbidities, yeah.
Could you first attach and say this just me, but I'm having trouble hearing some of your sentences. Could you speak a little more loudly?
Sure.
See if other people can hear you.
Sure, I can try to. No worries.
Thank you.
Thanks, Doug. So for every set, there's also a corresponding set of risk factors or initial conditions to allow for meaningful risk adjustment. So what do we do once we've developed this set, right? It's just a piece of paper. We have a pretty flyer, we have a pretty wheel that you saw. We do that. We have a reference guide that says, okay, here's another layer of detail. Here are the exact questions you should ask. Here are the time points you should do it at. But again, it's just a piece of paper. Even a publication, it looks nice. It has a nice logo on it. It has credibility, but it's not the end goal. And that's really the stage the organization is at, is how do we go from something that feels nice, looks nice, to something that actually has influence and power. And one of the first things that we see is a need to make it easy to implement, easy to get started. And that's the idea. I went a bit out of order here. I forgot that I put both those two slides in. I will come back to those. That's the idea of an implementation network. So to get everyone around the world who says, I want to collect these things on a web-based platform, speaking to each other, us sharing common resources with them, that they can get started, which includes looking at the existing solutions for collecting data, certifying them, rating them, helping you to make a decision of which provider should I choose to help me collect particularly patient-reported outcomes. We had our first webinar for this network a couple of weeks ago, and fascinating that people joined from all over the world. So obviously a heavy US, Europe, and Australia, but there were institutions elsewhere who wanted to be a part of this. We will see how fast it grows. We want to do everything we can, but it is definitely a journey. In addition to helping people implement our previously recommended sets, we also are developing new sets. So those were the 4 from last year, and these are the 8 that we are in process or just about to start this year. And the overall strategy is to continue to go deeper in a particular condition area, to move from low back pain to hip and knee osteoarthritis, coronary artery disease to stroke, but also to take on new disease areas such as depression and anxiety and mental health, cleft lip and palate and pediatrics. And the motivation and the thought process behind that is very much influenced by your work here, because our goal is in the next 5 years to cover over 50% of the global disease burden. And your work has been helpful in understanding what that is. The good thing is you can pick up quite a large chunk of that burden quickly with a small number of conditions. Having low back pain, coronary disease, and depression and anxiety already gets you a hefty way there. But even recommending and helping is not enough. We need to prove that. Why would you do this internationally? Why would you want to know a standard way of outcomes internationally? So we're developing a pilot project with the organizations who are first implementing the sets to ask the question, what is the variation in outcomes across institutions internationally? What can we learn from that? Our hypothesis is that the greatest variation will be global, and perhaps the most innovative institutions will be in places we least expected, because the pressure to innovate is different in other countries. I think one of the fascinating things you see in countries like India today is that they are able to achieve outcomes equivalent to the best places in the US and Europe, but at a small fraction of the cost, because there's tremendous pressure when you're delivering healthcare, often out of pocket, to drive down costs. So the question is, what could we learn if we were to systematically study those organizations to see if they were equivalent on outcomes? How can we adopt those operational practices back here in the US? And I think there's tremendous opportunity for that. This will be a methodological challenge. So if any of you are moving on from your fellowship here and need to take on a new challenge, there we work for you at ICHOM. It's a bit of a joke, but truly, in fact, I was speaking with Chris, your director, earlier, and he really challenged us on this. He was saying, definitely more than I understand methodologically, what his concerns were. So there are things to be resolved, but we are hopeful that we can come up with meaningful ways of benchmarking across health systems to drive learning. And finally, the last piece, the thing that I would call giving the teeth to the recommendation, is to get the system stakeholders on board. In a way, no matter what the field is, money talks. And until the people with the purse strings are saying you need to collect outcomes information, we will only have the early adopters. We will only have the true believers. And to get over that adoption curve, we need more power, in a way. The good thing is we're getting, in certain places, the payors on board, but we need more. The US is not on this list. They need to be. The UK, in some of their clinical commissioning groups, those are the groups that are paying for care, are engaged. In Sweden, a number of the counties have organized to pilot value-based reimbursement. They're engaged, and the Netherlands is quite engaged, but we need to do more. So that's also a task for the coming year. So before I end, I want to give you yet another quote from Codman, who we started with at the beginning, because I believe the goal of ICHOM in our day is to take his vision and to make it a reality. And this was something that he was hoping for even as he died, referring to himself as a soldier on the battlefield. So take a moment to read it. So it's our hope that we are the more receptive generation. And please come to our conference if you're interested in learning more. Feel the energy. Boston's only a 5-hour flight away. Thank you. Yes?
Could
could you say something more about how you arrive at the list of outcomes that you're going to measure for each of those conditions?
Yeah, certainly. So basically, what we collect is existing indicators. Often countries have quality registries where they're tracking a range of things. Those are typically quite traditionally focused on mortality and complications, often only in hospital. And then we take the clinical literature and look at more quality of life studies, patient-reported outcome instruments that have been developed. And we, in a way, meld those. And then even those two sometimes may not capture things that people think are really important. So the patient is queried, the other groups are queried, and we may say, we like these clinical indicators, we like these patient-reported, we think X, Y, and Z should be included. Is there a well-validated way of collecting those today? And then there's just a debate and refinement of what should be in, what should be out. Our goal is that we could come up with a comprehensive list fairly easily, but that's not very actionable. So we need to take the comprehensive list and to winnow it down until it feels holistic, yet parsimonious and feasible to implement. It's a challenge.
Regards to any of the 4 metrics you've done so far, or any of the ones that are in development, have you accounted for patient adherence to care ongoing as a measure being included?
So we haven't. It's an interesting philosophical question of accountability, but also tying processes, which could include the patient's own processes or the care providers, to the outcomes. And our view has been that we are standardizing the bookends. What is the patient at baseline? What is their end result? An institution would want to measure systematically what they do to be able to correlate what those differences are in what they do to the outcomes, including what the differences are in patients' adherence. But we don't standardize those on an international basis.
But surely when you move on to depression and anxiety, you're going to have to touch on it somehow, right?
Why would you say that?
Well, in my experience at least, for depression and anxiety and other issues of managed care and behavioral health, so much of the end result process is not just the touch points with the care, but also how the patient deals with that care outside.
Mm-hmm.
Either adherence to medication or continuing of behavioral practice outside of clinical setting.
Yeah, so it's an interesting question you would raise. So if you were to collect outcomes for patients with depression and anxiety, you have their baseline, what their level of depression and anxiety were. If you were to look at a center that achieved better outcomes than others, perhaps the question is that center that much better at engaging the patients to do theirs? And that's what you want to look at. So in a way, this starts the conversation, but it doesn't end the conversation. I don't know if you're familiar with the positive deviance methodology, but it very much fits into this principle of there is variation practice today. First, we look at the positive outliers and we determine what it is that's different. And some of those things may be ways of engaging the patients that then we can study more systematically to show the impact of those things on the outcomes. Yep.
One of the challenges in this field is limitations to people feeling like risk adjustment is adequate.
Mm-hmm.
I was wondering if there's been discussions with your group and others about sort of a new way to solve that problem, because our old ways don't work out well.
Yeah, no, it's a very good point. Risk adjustment is always the question people ask, particularly when you show variation. It's, well, is that risk adjusted? It doesn't account for enough of the differences. And that is true. The question is, does that prevent us to learn from the data? So is the risk adjustment so poor that we can't even do the comparisons? Or is it sufficient that we have some directionality of who's probably pretty good and who needs to improve, but we don't know whether you're 3 or 4? And I think that's the problem. We get so hung up on the ranking that we miss the opportunity for learning. Our view is that the focus should be on learning first, being comfortable with the data, and over time we'll build a trust in the risk adjustment. And that's what you've seen in fields like cardiac surgery. The first reports, not very well risk adjusted, caused a lot of problems in New York, but the society has owned the development of risk models and now has many institutions voluntarily reporting because they trust the data. That took 20 years. It can't take that long. We got to move it up closer, but I think that psychological sequence is still important.
When you look at depression and anxiety, I mean, there's so big cultural differences in the way people define those issues and the way people get treatment in different countries.
Mm-hmm.
Don't you think it's a big challenge to compare across countries, and in the future, if you want to include developing countries, and I think it's going to be a very big challenge.
Yeah. So I knew you guys were going to challenge me with methodological questions, which is good. That's what we need.
Not methodological, more cultural, yeah.
Yeah, it's how would you get around that methodologically, and can you? Right?
Yeah, that's.
So it's a very good point. I would say that the first focus is learning locally on the improvement. So the delta, we were speaking about this, Peter left, but with Chris Murray as well. If you look at the delta rather than the absolute level at the end, does that in a way self-correct for cultural differences? Perhaps some. But the first impact is to look at that delta locally. To what extent is my institution and my treatment practice having an impact on the patient's depression and anxiety? And you can do that. I mean, people do it in the UK very well in their IAPT program. You can show the impact of treatment, and you can show the variability in that impact depending on the center. Once you move internationally, are they going to be perfectly comparable? There are going to be challenges. And that's why the first focus is on the learning piece. It's not to print in the New York Times the list of institutions around the world. It's to get people together, talking about outcomes, talking about differences in practices, and discussing how to improve. And I think the methodology will develop. Yeah.
Doesn't the leapfrog group do something similar? Is like looking at outcomes?
So the traditional focus has always been very narrow because they've used existing data. And the problem with existing data, it's just not that comprehensive. You can measure, they use mostly administrative data. You can measure hospital-wide mortality. You can measure hospital-wide infections. They don't typically measure things on a condition basis. And they don't measure most things that matter to patients from a quality of life perspective. Yeah?
Continuing with Laura's question, I just wonder how well this may translate to others, like low and middle income settings, or even low income communities in high income countries, where maybe choice amongst healthcare providers is secondary to access of the providers in the first place.
Yeah.
I was wondering if you could comment on that.
Yeah, so that's a very good point. The focus here is on the delivery. So access is a separate problem. You could use measures of incidence because you're collecting baseline characteristics to measure whether prevention or screening is appropriate. But that's not really the target. What I would say for that, what we need to develop are sets of outcomes or indicators for effective population level interventions. So if you were looking, one idea that I've had that I think is quite interesting is to look at the population of at-risk for, say, cardiovascular disease patients, which is a huge population here in the US. And there is a small number of mostly behavioral health issues, not behavioral health from mental health, but behavioral issues around what's driving that risk. You know it because you wrote on it. It's smoking, it's physical exercise, it's diet. And you could define a set of indicators that encourage and drive improvement along those indicators to prevent the development of cardiovascular disease. So I think for me, the population, at least the preventative care aspect, would need to look at a different angle. The access issue for a defined condition like, say, localized prostate cancer, that is a kind of a policy question, but it's not a delivery question that we focus on. Yep. Yeah.
I think this sounds like a great idea, and I'm glad you came here and told us about it. I'm wondering, this is an observational approach
Mm-hmm.
to learning from clinical practice. So it's not included to learn from randomized trials and that type of thing. So then, of course, like some people already mentioned, there are analytic challenges. And do you have any analytic strategy? Are you going to have data centralized, or will it start to be a decentralized operation, or?
Yeah, very good question. So people ask us, do we need to send you our data when they first hear about it? And we've made the decision that the emphasis should be on institutions or regions, depending on how they're set up, to collect the data locally. So we would encourage the development in every country of a systematic way of measuring and reporting outcomes to that country. This is the model of the quality registry. But what we would like to organize is a layer on top of that to say, within a small set of indicators, those defined in the standard set, to pool on a project basis de-identified patient-level data to conduct a comparison. That's the current model. There are still regulations that are still challenging to overcome, and we've got someone who's from the law school who's knowledgeable about it, who's working on that. But that's the strategy. There are options for doing distributed research networks where you don't have to pool the data. They're more challenging to set up operationally, but they would allow for many more research questions to be asked over time. So we'll see where that goes. It is not an easy thing, primarily from a data ownership perspective.
I'm not sure, maybe I missed. Did you say you were going to look at the cost as well?
So we are the outcome side of the value equation. We had this conversation earlier. What should be our role in linkage to the cost piece? I see the linkage as, if you were to design new reimbursement models, you would want those reimbursement models, which are going to be more comprehensive than paying for activities, as we do today here in the fee-for-service. You'd want a broader set of things included, and you need to tie it to outcomes somehow, because you want to give providers flexibility of what to deliver within a broader bundle. So the view is to try to link the outcome sets with new reimbursement models. So we're meeting with people from Center for Medicare and Medicaid Services, from some of the private payers to do that. At some point, that bundle with its associated results that are achieved on average will have a price. And that price ideally is a competitive price that's transparent. And that's where the linkage comes in. The cost of how to achieve it, we think, is the institution's problem, whether they can achieve that price at a margin or not. Yeah.
Caleb, is around intervention. So your focus is on the condition.
Yeah.
Now, it doesn't seem to be a very tight linkage to the mix of interventions that may be involved. Is that potentially problematic? If a new intervention comes along, then maybe the existing set of outcomes would have to be revisited? Yeah,
it would. So the model, which I didn't go into, is that the sets are something in evolution. They should become more, not necessarily more comprehensive, but continue to reflect the challenges that people face today. And as certain outcomes are no longer relevant because we've innovated interventions that no longer affect those, others will become more important. So a subset of that working group becomes a steering committee that governs the set over time.
You don't have a definite sort of cycle in mind that you'll revisit each condition every
Well,
years?
we've put a more aggressive cycle in the beginning because it's early. So we're revisiting it on an annual basis to look at it. Whether there's sufficient new information to change the recommendation, we will see. But it will be informed not only of new practice, but also implementation. Because if people implement a question, they say, well, we try this in our clinic and people simply won't fill out this long form, then we need to pay for someone to optimize these instruments to shorter versions and things like that. So there needs to be a process for that feedback to get back to this group and to refine the set over time.
Sort of to bounce off of that, I think that brought up an interesting point of as new technologies come around. Sorry, I also been trying a little hard to hear the last person answer, but so sorry for repeating what you said, but I think that once again, more methodologically, I think we'd be interested to see how you take that into account. Because what if a new technology comes around and we actually see a dip in outcomes because people aren't used to it, right? You basically go from someone's performing 200 surgeries a year doing the same way, now they're doing 200 a different way. You can't expect the same
I don't know. That's a good question, and not something that I've really thought about. The Martini Clinic example that I mentioned, if they're going to test a new operative approach, which they do quite frequently, one surgeon will test it and observe its impact on outcomes. And typically, they're not looking at the long-term outcomes. They're looking more intermediate outcomes like the 1-week continence level, and it's more the 1 week's incontinence level, which correlates highly with erectile function. And they're looking at those different operative techniques and how they impact those. And if they get a significant enough sample, then they'll roll it out across the institution. And then their practice has people visiting it all the time, and they are in an area of an epicenter of innovation that can spread an adoption curve. So I would say that you would want to build enough of an evidence base to adopt a new practice within an institution. Hopefully the adoption curve would be such that at least on an aggregate of 1 year, people would have adapted and improved and not taken too many patients through the learning curve, in a sense, in that process. Yeah. Please.
Is this exercise going to really help promote better care delivery? Because I can think of a scenario where this gets picked up by every institution, but it turned into a competition where hospitals will start to reject high-risk patients in order to get better statistics. And it actually turned into worsening the system that high-risk patients don't get the benefit of going to hospital because hospitals want to preserve their reputation and like having good statistics. And people can even move towards like auditing, changing the data in order to look good on the list that we have. So is this necessarily going to make life better for patients?
I think it will. There is a bit of a faith in the process. What we have is broken, so we have to do something. And we have to figure out the path forward together. The risk adjustment will be challenging, and we need ways of assuring that that's not happening. From a methodological standpoint, I think you can, in a way, even incentivize high-risk patients, because it all depends on how you weight those in the model. And you could add actually extra money to take care of the highest risks patients that have the ultimately probably the most benefit. But from a gaming, more issues in the system standpoint, it's going to take monitoring. It's going to take a process to get there. And that's why I feel that the first step is to get people to measure and to encourage measuring and reporting, get to trust in the data before we go and stick it in the newspaper. So that's our view, and that's what we want to sell to the health plans and the government, to say, be patient, encourage measure, you'll reap the return in the long term as people improve outcomes, they standardize their practice. Don't demand the data to be on the front page of the newspaper overnight. But we'll see if they take it. Yes?
Question, what's your vision on what would be the end? Finally, the inequality between centers would be decreased or increased?
It should be.
I mean, that the institutions are, categorized into two groups, high performance and low performance. So those that pay much more, they get higher performance. Or overall, at the end, they all would be good.
My personal view is that there will be consolidation in the market. You look at healthcare, it's a tremendously fragmented market. How many other goods and services, besides a restaurant, does every local institution operate independent of others? There's very little intersection or intercommunication across providers. And so what you will likely have is a consolidation around the high volume, hopefully high outcome providers, and they will start to either themselves own and operate or influence the care across the country or even across the world. You see this in places like the Cleveland Clinic, who've taken their cardiac surgery practice, which was renowned in the US, and then they've taken the model, they train cardiac surgeons and then implant them in regional hospitals all around the area. So I think that would be the end goal. People who do very little delivery or very little volume in a particular condition and have poor outcomes would stop working in that area. They would focus on other areas where they're good. And eventually you have a smaller number of providers in a particular treatment area.
But it doesn't interfere with the distribution of service.
It doesn't have to.
Service in better rural, urban areas and
So it's a question of whether the volume has to be centralized physically or whether it needs to be centralized organizationally. So it is a problem if the model is to build a huge cardiac surgery factory in Cleveland and everyone in the whole US is going there, right? But if Cleveland can figure out a way of delivering care locally, but influencing their practices, they use the same information technology platform, the same protocols, the same training, then perhaps they can achieve near equivalent outcomes even in your more local institution. So I think it's a balance. There's probably some physical concentration, but there's not going to be complete concentration.
One question, Caleb, about the patient involvement in your panels.
Yeah.
Has it really worked well? Are the patients, firstly, how do you select representative patients?
Yeah.
And secondly, are they not inhibited by the professors all around them?
It's a great question, one that we've struggled with, really, to be honest. We selected them by going to patient advocacy groups who have typically patients who sit on these type of committees, so they're experienced in interacting on these settings. So the patient who is involved in the coronary artery disease group, he actually used to be the chairman of the board of the AHA, so well articulate, politically influential, and he tried to follow in the discussion. They can generally follow the outcome discussion because it's about things they care about. They can say, well, this was my own experience, and when I took the patient surveys, this is what I felt more represented what I care about. When it gets deeper into both the methodological questions of the outcomes and then into the risk factors, it's really hard for them to contribute. What we did that I thought was well, though, is we had the patients in the first groups work together to write a paper of why this mattered to them, and they're actively working through their advocacy communities to promote it. So I do think they're important. I think having a voice at the table is the most important piece of it. But over time, I would like to see more engagement in testing the measures with the patient community and receiving their feedback in a systematic way to revise it over time. Beck?
How did you select the conditions that you developed, the original 4 and then the follow-up list of conditions for these standard sets? How did you decide on which ones to?
Yeah. So the broader list of 50 is based in many ways on the WHO GBD work, your work, to say here's the set of kind of big ticket items that you'd want to get. But within that, it's more opportunistic. It's who do we know who's engaged on this topic, who has a strong network internationally, could organize a group together, and is there funding to support the group? So that's really the priorities that have driven the 12 that you've seen. If we had funding that wasn't tied to a condition, which is something we're actively looking for, then we would probably progress more systematically through the remaining conditions.
One last question. So
Yeah.
if you look at like your survival outcome that you're trying to track per institution, right?
Yeah.
Don't you think like the retention of patients is too low to actually get valid outcomes? Because like who is going to stay with one provider for like 5 or 10 years?
Yeah, so the survival outcomes, that's a question you always ask is, what's the right method to track this outcome? And the survival outcomes, the recommended method is through death registries. So you have the patient, you have their social security number, which I know in the US is a problem now because of the new rules around death registries. But you'd be able to look up to which of those patients had died at 5 years or 10 years. Other things, it is a problem that we don't have a national identifier here in the US. So they're going to be easier for other institutions, other countries to implement. But hopefully that provides us a push that we can get our sometimes backward healthcare system on the right track.
Finally, of course, once you've got the systems in place to collect all this wonderful outcomes data, then you can pass it over to IHME. Well, thank you so much. It's been a fascinating talk.
Thank you.